Well, the roles are a little reversed. It's always hard to follow a great Arva Porzian talk on electronic education. And really should thank Ara for really leading the way for this, for CT surgery. I want to thank the committee for inviting me to talk about this. It's actually sort of talking to the converted here. You know, all of you guys are mentors. And I think you know, what I hope to do today is maybe just reflect on it a little bit and maybe use some other potential tools to help us do a better job with particularly the medical students. And I subtitled this talk on Masters, Muses, and Monsters, because I think that's we're all sort of a different breed within this room. And just to start a little bit, the other day we were in a focus group, and they asked, how did we get into thoracic surgery? What really got us into this field? And maybe just have a quick poll. How many knew they were going to be a thoracic surgeon when they were in high school or college? Okay, how about in medical school? Residency? Okay. How many were born to be a thoracic surgeon? Okay, so from there, I have no disclosure. So from there, what I hope to do is that you sort of reflect upon your mentors and really apply some of the positive things that you've done for the medical students, because they are a different breed. And to get myself started a little bit, I was in medical school and I really was interested in thoracic. I spent a month on the service. My two main mentors is Dr. Brooks, who some of you may know at the Medical College of Virginia, and Richard Lauer, who was one of the leading pioneers in cardiac transplant. Dr. Greenfield was the chairman, and I remember him running around with all of his little pulmonary embolectomy catheters and following him in the middle of the night trying to suck out all those PEs. So briefly, over the next couple minutes, what I hope to do is go through four things. A little bit of general background of what mentorship is, some of the trials and tribulations of being a mentor, some of the special programs that we have both nationally and our local places, and then finally, some of the concrete examples of mentorship within the Cardiothoracic Surgery Society. So just to talk a little bit about history, hopefully you know what mentorship comes from. So in ancient Greek mythology, Odysseus, the king of Ithaca, went to fight the Trojan War and entrusted his son and kingdom, his kingdom and his son Telemachus to mentor. Well, it turns out that the teacher mentor was actually Athena, the goddess of wisdom, who was in drag or disguise, whatever, however you call it, back then. So when we talk about being mentored, being a good mentor, what is that? It's not just to give advice. I think if we ask people here, which we don't have time for, so what is a good mentor? What do you do? What is your role? And so I think that question is very difficult to answer. There was a book by Daniel Levinson called The Seasons of a Man's Life, or a Woman's Life, and it really reflected upon the philosophy of how you go about changing your own self and improving yourself. And in that book, he said the most important function of a mentor is assist in the realization of a dream. Remember, it's not your dream that you want to pass on to your mentee, but to make sure that they achieve their dream. So when you look at the anatomy of a mentor, there's different types of mentors. And again, just to go through my life very briefly, I had the mature faculty, which was Dr. Brooks. The expert was Dr. Lauer. One of the people that really influenced me to really take that next step to be a thoracic surgeon was Tom Daniel. He actually was in private practice at the time, and then at that moment, our lives changed because I decided to go into thoracic surgery, and he decided to go back into UVA. The leader of the institution was Dr. Greenfield, and one of the big cheerleaders was an older gentleman. I don't know if you all know him. He's, God, I'm blanking on his name right now, but he really loved teaching the medical students. He was a big oncologist. I always kept in touch with my teacher, Mrs. Winfield. She was my high school biology teacher, and she always kept up with me. So she was one of the big mentors in my life overall, because she always wanted to make sure that I was doing the right thing and that I was going to pursue something in science. And then finally, you have your family. My parents have always been a great coach. And at the time when I was in medical school, this the funny story of why I wanted to be a thoracic surgeon, because at the time my girlfriend really loved thoracic surgeons, and so 30 years later, she's still my girlfriend, but my friend and my moral supporter. She's in the back of the room there. So as you can see, the mentorship is actually very complex, and what we call mosaic mentorship now. So students and residents don't need just one mentor, but they need different mentors because we all provide them our strengths. You know, I can't be a good psychologist. I can't sometimes be a good person to talk about work-life balance. So they have to find those other people. So why should we mentor now? You know, we got a great I-6 program. The numbers look great. You know, we're fulfilling all the spots. But we still need to do more because we have to keep pressing on those medical students. So we still have to introduce and instill the positive traits of earlier generations to diminish and eliminate those traits that are not conducive to a successful career in cardiothoracic surgery. We need to stop looking toward the future and expecting to see the past. I think some of us who are older still see that. Say, geez, I wish it was in the old days. But we really have to look forward now because things do have to change. So there are three things that mentees expect. So the first thing is they do require personal feedback. They need the encouragement, the support, the candid information and advice, and your very honest appraisal. I mean, you have to be quite honest with them. It's been very heartbreaking for me to tell students who want to do CT surgery and say, listen, you don't have it. You don't have the technical skills. You don't have the knowledge. And then you have to guide them into something else so that they'll be successful. The second is to discuss their career, the big picture, some guidance on some major actions, some different approaches, some help with their vision, making good choices in their life, and finally, reflect a little bit on your own experiences, what worked and what didn't work. And finally, this has to be a very serious relationship. You can't be their friend. My wife says, don't be their friend, okay? You can't go out drinking with them. You can't go be playing paintball with them. So you have to be very serious. It has to be in the workplace, confidential. Always give them available opportunities. So you always think, well, I want to have them work in our lab. Well, have them go work in somebody else's lab because you know they'll probably do a little bit better job with them. Well, what are some of the challenges? Well, it's the investment of time and of yourself. You have to follow through. You can't just meet them that once, expect them to sort of keep following. You have to keep emailing. You have to keep calling them up to see what they're doing. You need to make sure that they're compatible with you. Okay, so the personalities, if they clash, then you're probably not going to get off a message. You have to be very, very patient with this new generation, and we'll talk about that in a second. Now, there are some special situations. Everybody always asks you, can you take my kid? You can take my family? Can you take your nephew? Those are hard, okay? Now, I would probably not do that. Now, I don't have any family like that right now, but I think it's very difficult in those situations, so I would sure make sure that those are passed off to someone else. And finally, there is this issue with the generation gap. I think it's a very important thing that you all know because they're not like the students that we used to be. They have some different priorities. Now, just a little about the demographics. They're ethnically diverse. Only a third of them are not Caucasian. A quarter live in a single house, a parent house, and 3/4 of them have a working mother. They prefer directness over subtlety, action over observation, and they felt very protected until 9/11, but now they feel very vulnerable. Now, they're very electronic savvy. I'm not going to go through all these statistics. They own almost everything in the world. So that's why it's important for you all to do some of these things, to understand what Ara talked about with some of the electronic education, because if you don't do that and you tell them to read books, you're not connecting with them. So you really have to do a few of these things. Now, a little bit about their ethics, which may surprise you a little bit. So 82% of them lied to their parent within the 12 months. I mean, I'm part of it too. I lied to my parents still. 62% lied to a teacher. 60% cheated at a test. Now, they like to steal stuff. So about a quarter of them stole something from a store, from a parent, or even their friend. And then finally, when they asked, well, how do you feel about that? Well, 92% said, I am satisfied with my own ethics and character. Okay? So it's a different breed. So how do you mentor these people? So for this generation, we need to understand their perspective and values and not really pass judgment. You need to involve and adapt the positive attributes and shun the negatives. And finally, to create a culture where mentoring is the norm and not a random event. We also need to control the message. Since they are somewhat overbearing sometimes, you need to drive them and tell them what is right and what is wrong. So make sure you continue to drive the message. It's also important to know what they're saying about us. There's a lot of blog sites out there, and since this is sort of the interview system, I'm sort of share you the main one's called the Student Doctor Network. And if you Google that, it's got a lot of blogs on there. And for you program directors in the I-6 programs, you need to read these comments about the current interview process. Okay, there's a lot of negative stuff there, so you better read this and try to dispel it, okay? So go to these websites and read a little bit about them. I'd like to talk a little bit about some of the initiatives that the CT surgery community has been doing over the past decade or so in structured programs for CT surgery mentorship, particularly for medical students. The ATS Scholarship for Summer Research has been going on for about 8 years and has given out about 250 scholarships to medical students, to first and second year medical students, to work in the lab for 6 to 8 weeks. The SCS Look into the Future has been existing for about 8 years, but has given about 90 scholarships out to medical students over the past 4 years. The leadership's been done by Rishi and Bob Higgins, R. Vaporsian. So really we want to thank them for allowing us to continue to mentor these medical students into our specialty. I had the privilege of helping, along with some of my MCV colleagues, to set up the Brooks Scholarship at the STSA organization. We've been giving this out to the more outstanding fourth-year medical students who are pursuing a career in cardiothoracic surgery. Rishi set up the STS Look into the Future webpage, and it's a really great conversation area where students give us feedback. We try to answer some questions online, but I encourage you to look at that Facebook page, because this is what the medical students are talking about these days, and this is how they like to communicate. There's numerous summer scholars awards throughout the country. If you just Google it, all these institutions, Mass General, University of Minnesota, Ohio State, Stanford, University of Iowa, UT Southwest, Kentucky, and Hopkins, we give out one to 5 awards per year. In my office, we have a plaque that we put all the medical students on there on a yearly basis. We had a family who donated money. I pay them about $1,500 each, and we celebrate it with a dinner in the fall. I think if you don't have that, really want to celebrate these kids, okay? You want to try to do some development with your patients. It doesn't take a whole lot of money. I mean, most people can't give the 6 or 7 figures, but if they're willing to give maybe $10,000 to $15,000, that's enough to support one medical student and have their name for eternity. And finally, the Women in Thoracic Surgery have really done a great job. They've been doing this for about 10 years and giving an annual award to the medical student, and we really want to thank Carolyn Reed for her work with that. This also has really touched off a lot of educational research. So it's not just a matter of just giving awards out and trying to see what students do, but you can actually study these students. R did that a few years ago. Rishi's written a lot about the Look into the Future Award. There's also the UNC folks under Rick Fine's guidance has done a lot of work with simulation and the medical students, showing that this has catapulted their interest into cardiothoracic surgery. So again, another area that's primed to work with medical students. Bill Baumgartner and Vince Scott at our institution actually started this intercession program where for 3 weeks between the winter and the spring semester on the undergraduate college, we bring about 3 to 6 undergraduate students, and they shadow us for 2 weeks. And we've published this a couple times and showed about 20% of them do end up going into surgery, although a small fraction go into cardiothoracic surgery. But it just takes one person to go into CT surgery to really let you know that this program does work well. There's some specific local mentoring activities. I've talked to some of my colleagues around the nation. These include like a Gray's Anatomy Watch. They'll take one of the programs that's centered around cardiothoracic surgery, and you sit there with the medical students for about an hour and a half over pizza, and you talk them through that case scenario, and they really enjoy doing that. We go out maybe once every 2 months with a bunch of medical students. I call it Sup with a Surgeon. I know a lot of folks bring students to their home and show them how to suture. You can have a wet lab or a robotics lab. They have outpatient shadowing. They have a transplant call system, CT surgery interest group. So if you don't have one, everybody has a surgery interest group, but these days they're starting to fraction. There's neurosurgery, there's orthopedics, there's plastics. You should have a CT surgery interest group because that is another way of attracting them. We've developed a preclinical surgical curriculum in the first and second year of medical school because I wanted to show that to the clerkship directors that I can teach a first-year medical student how to do an aortic anastomosis. And this, I know it doesn't look pretty, and you can see a little bit of a crimping there, but this is the first aortic anastomosis by a first-year medical student 6 weeks into medical school. So just imagine what you can do with that student about 2 to 3 years down the road. Some other preclinical activities that you should get involved with at your own medical institution: participate in the first and second year curriculum. You need to get to these students much earlier these days. So go to the dissection lab, do clinical correlation lectures, go to the introduction of clinical medicine and skills labs, start a surgery interest group and participate. I did this for several years. I had about 60 to 80 students come to the house, and we call it Operation Pumpkin. So they come in, they carve a pumpkin, and I teach them how to suture. It drove my wife crazy because at the end of the thing, we had like 30 pumpkins sitting in the front of the yard. But you know, this is what interests these kids. First year, when they get there, they want to learn how to suture. So this is a cheap simulation environment. Serve as a faculty sponsor for other activity groups. It doesn't have to be surgery. As you can tell, I'm Asian, so I'm the faculty member for the Asian Pacific Student Association. So they want to see that you have interests outside of the operating room. So it could be anything. Paintball, we do the dancing, as you know. So we have a little dance group that we go out with some of the med students every so often. So they don't want to hear you say, I work 120 hours a week and I love it, okay? They want to hear that you have a life, that you go play tennis, that you go do other stuff, you go golfing, you go to these great meetings. So don't focus too much on how much you work, but how much you love that work. And finally, another source is to serve on the admissions committee. There aren't too many surgeons on the admissions committees at Hopkins. There's probably 2 of them. But then again, that's another great way of introducing yourself to these potential candidates. Almost all of them end up coming to Hopkins who get their interview. So you introduce them early, you give them your card, and they end up calling you the first day they enter the door. During the 3rd and 4th year initiatives, get involved with transition programs, either transitioning from the classroom to the clinical years or the transition from 4th year student to internship. Get involved with the basic surgery clerkship, volunteer for lectures, go to the lab, let them sew when they're in your operating room. Hold meetings with the surgical applicant group, so if they're going into the I6 or even the general surgery program, help them with their residency applications, the interview process, and some of the pre-match debriefing. Now, Rishi published this study a few years ago on looking at preclinical students, looking at college students. Should we be dipping further on that 1st and 2nd year medical students may actually be too late? So some things that you can do at your local places, local colleges, health science clubs and science fairs, intercession experiences, summer jobs, grade school career day. They love hearing about all the different types of careers in medicine, not just surgery, but nursing, anesthesia. Bring your team. Have them come and meet your team at the institution. And if you have a meeting in your local area, bring them to that. It's cheap. They don't have to pay for anything except for probably the parking. But be your mentor for that meeting. So I think surgical mentoring is a little bit more complicated than mentoring for the other medical specialties because it's more common for us. We're with them on a day-to-day basis. We're with them for more activities than, say, with internal medicine. But you have to be very cautious because they're all different. We're all different. So there's different personality traits, there's different behavioral adaptations, and then there's sometimes unusual stresses that derails the mentee. So again, if they come to your operating room, you got to act a little bit nicer. You don't want to show them your true colors, okay? So be very, very careful when those students are there. So just to end up with a couple personal mentors, so some of the things that I looked at when I was growing up, were they skilled technicians? I was going to surgery, I wanted to see those people. The egos were outshadowed and contained by their intellectual honesty. Complications were viewed as personal failures, not variations on expected outcomes. Quality surgeons are always learning from successes and failures and rarely make the same mistake twice. And finally, they respect their patients and colleagues. Their respect and adoration were universally returned both in and out of the operating room, so be very respectful. As I mentioned, this day and age is more mosaic mentoring as opposed to one-on-one mentoring, so you have to shuttle them to those people who are expert in clinical, basic science research, personal things, community service, political strategy, communication skills, and leadership. I can't do all those things. I don't have all of those hats. So we serve as temporary mentors to triage them to other folks and match them with the appropriate mentors in their defined areas. And it also avoids the drawbacks of traditional model problems, say sometimes with personality differences, sexual issues, or time limitations. So you really want to create a mentoring environment. All surgeons are encouraged and expected to mentor. Leaders, educate your younger faculty because they will be your next generation of mentors. Mentoring should be a valued activity in academic medicine. We don't get paid for it, but somehow it has to go into promotion. You have to compensate them for their time or have them have protected time. And set up some way of measuring their success. It's very, very important for those of you who do a lot of mentoring to fill that out in your educator's portfolio. Not just the I saw this kid once, but what are they doing? What kind of awards? What are they doing now? Because the good mentor knows all of these people in their educator's portfolio. Frank, if I can just get that brief. Now, this is one of our funniest mentoring videos, and just take 2 minutes. This is what we usually show to improve your mentoring techniques. So I think, like I said earlier, get involved with them early in their clinical years. I'll tell you, the third-year clerkship, it's too late. It's really too late these days. Engage in activities outside the hospital, okay? They want to see that you have a life. Emphasize to your residents the importance of mentorship. We probably don't do that enough, but you have to make sure that you tell the residents we need to mentor these kids into CT surgery. As I said, recruitment of young people is vital. We must start much earlier than what we used to do in the old days. It was once put out by David Thomason, who used to be the dean at Harvard, and he said, we must acknowledge that the most important, indeed the only thing we have to offer our students is ourselves. Everything else they can read in a book, and I added, or can find on the web. So again, I want to thank the GTSC for the privilege of speaking to you all today, and I want to thank each and every one of you for all the mentorship that you do for the residents and the medical students. Thank you.